Thank you, Dr. Arvin. Sorry, if I need to leave after this, I'll take up your questions and then I'm leaving. So it's just because I've got a 4-year-old having temperature, not because I don't like you. My talk is going to focus on the work that Dr. Arvin and I did for the past about 12 months. So it's been a nice adventure. And in the background, I'm an engineer, so I'm a biomedical engineer. So I feel very nervous giving this talk because I'm talking about things that you are all experts in, and I'm probably going to make mistakes. But yes, any feedbacks, welcome. So just to give you a bit of background about myself. So when I did my PhD, I did a very similar topic as what Professor Kochter talked about previously. I modeled the second stage of labor, and it was a very challenging piece of work. And also 10 years ago, the computer power was not as good as now. So after 4 years, I decided, okay, I need to change my mind and do something else. But I'm still very much enthusiastic about female health area. So when the student approached me with Dr. Arvin's project, I thought, oh yes, let's do that. So I'm back in the field. So you probably all know about why preterm birth is important. So I'm going to skip through most of that. So 15 million babies are born prematurely each year. Obviously, for low-income countries, the mortality rate is much higher compared to high-income countries. That sort of, in a way, contradicts to what Dr. Arvin was talking about between the West and East. It is a huge economic burden, so if there's any ways that we can prevent this from happening, it will be beneficial to any healthcare systems. So this is where I'm getting into the zone that I'm not expert and everybody else is expert. So there are a lot of factors that contribute to spontaneous preterm birth, but what you will see is sort of the funneling of the cervix, and then it opens up, which is not supposed to happen during pregnancy. From an engineering perspective, and from reading to the literature, we know that there are a few treatment options for preventing incontinence in cervix. So you have got the cerclage, you've got progesterone treatment, and then you've got the Arabine cerclage pessary. So we're interested in looking into the Arabine cerclage pessary for the reason being that it's a relatively cheap option to try to prevent spontaneous preterm birth. It's using medical grade silicone, non-invasive compared to sort of the other procedures. But we know that there are ongoing clinical trials trying to confirm how effective that is. So we thought, why not use computer models to simulate the effect and see what kind of mechanical support does having a pessary in a weakened cervix provide to the mother and the baby. So that's what we set off to do. We looked into the literature. There hasn't been much work done on that. We found only one previous piece of work. It's published in a PhD thesis format. And in that work, Fernandez in 2017, which is still quite recent, they created a lower uterus cervix finite element model, so which is this one, and then they created a model of the Arabine pessary and inserted it and looked at the distribution of stretch and stress in the tissue. So when we started looking into the problem, we took a simplistic approach. So the question we asked ourselves is that how much structure or tissue do we need to model in order to see some effects? So we thought, okay, we start from a simple model as possible so that we can get results quickly. So what we did is we used a simple material model and we looked at the increase in intra-abdominal pressure during pregnancy. So we found some data in the Beta publication. So they've reported intra-abdominal pressure in non-pregnant, and then first trimester, second trimester, and third trimester. Oh, sorry, that's not intra-abdominal pressure, that's the material parameter for the cervix. So as you can see, is that as the pregnancy progresses, your material or your stiffness of your tissues become softer. Essentially, it's saying that your body is preparing for the labor procedure. So your muscles, your cartilage, everything is becoming more loose, essentially. So we're capturing that in our model as well. So as Dr. Arben mentioned, we've got 2 cases of MR scans from Professor Yanni's group in Brussels. What they did was they collected MR before the pessary insertion and after the pessary insertion, and also followed up a few weeks after that. So from these 2 patient scans, we created computer models of their lower uterus and cervix. So these are shown in red. So that's patient 1 and patient 2. And we've got the CAT model provided from Dr. Arben's group. And we basically inserted the pessary into the computer model of the patient virtually. And then what we can look at is how loosely or how tightly you could insert that pessary. So obviously it's difficult to try it on an actual patient, but in a computer model you can do it very easily. You basically, if you want a tight position, you push your pessary right against your cervix. If you want a loose position, you make the distance longer between the front of the pessary and the cervix. And we also tested another case which was median, so it's somewhere in between. And then we also thought, okay, there was some previous ambiguity about which is the upside and which is the downside of the pessary. So what if somebody put it upside down? And it's easy to test it in the model. So you just need to flip the pessary and put it upside down, and you simulate it and see what happens. So we did this for patient 1, looking at 4 different positions, and then we did the same thing for patient number 2. So I'm not going to bore you with exactly what we did in the simulation. But before we start, we did try to verify our model, because we have the MR scan before and after the pessary insertion. So what we did is that in our computer model, we inserted the pessary, and then we looked at the amount of displacement after pessary insertion in the model. We then compared our predicted displacement versus what you actually see in the MRI scan to verify our model. So we looked at it qualitatively by just eyeballing and see how your cervix location changes. We also did it in a more quantitative way, where we looked at the vertical displacement of this yellow point, and we also measured the actual opening of the cervix. So from the qualitative verification, what we can see is that with the pessary device, the model seems to predict quite well the behavior of the pessary. So basically it lifts the cervix upwards and distally, which is also what we see in the MR once you inserted the pessary device. And when we looked at the quantitative numbers, so what is the cervix diameter before and after the pessary insertion, we also got confirmation that looks like the model is predicting the correct behavior of the cerclarch pessary, which is also good. So once the model is verified, we move on and look at doing some investigations in the models to check what are the effects of different positions. So we looked at a few different things. First, we looked at the increasing in intrauterine pressure from week 26 to week 33.4. with and without the pessary. We then looked at 3 different pessary positions, whether it's a loose or a medium or a tight positioning, and then an upside down pessary. So, with the 3 types of pessary position, so we apply the same conditions to our virtual model. The only difference is that the position of the pessary is slightly different. The loose one is further away from the cervix, and the tight one is right next to the cervix. And we also applied the intrauterine pressure to mimic an increase from week 26 to week 33.4. So here's what the model showed us. So the purple one is without pessary, and all the blue ones are with pessary, with different degrees of tightness of how you position that. And what you can immediately see is that comparing between the purple and blue, all the pessaries, the patients with pessary, the models, they're all lifting upwards and distally for the cervix, which means if you've got the pessary there, regardless of how loose or how tight you are fitting it, it always provides support to the cervix and prevent it from opening further. That's just showing some of the strain or stretch map that is predicted by the model. There are a few previous talks that mention about pressure and how the patients feel sort of pressure coming down their abdomen. So strain and stretch is related to the sense of pressure. And what we find is that the pessary seem to distribute the strain and stretch much better at the cervix area, which correlates well with a sense of relief in the area experienced by some of the patients once pessary has been inserted. So we think the pessary does provide support mechanically to the cervix, and it does help relieve some of the intense pressure in that localized region if you've got a short cervix or funneling in the cervix. So regardless of how tight you position the pessary, it always reduces stretch, which is good news because you don't want the cervix to stretch even further. The medium positioning seems to provide the most reduction, but the result is not significant. So any type of positioning seems to provide some support to the weak cervix. What is interesting is when we look at the incorrect positioning, which is the first column. So compare incorrect with a loose position and with no pessary. If you accidentally inserted the pessary upside down, it actually makes the funneling worse. And when you think about it physically, it makes sense because the opening is wider on top and narrower at the bottom. So what you are trying to do by inserting it that way is actually forcing the cervix to open on top because you've got a mechanical restriction at the bottom. So what that result tells us is that that should be avoided because you are actually making the funneling worse rather than what the intended use to be. So whenever somebody does a cartoon or illustration about inserting pessary device, they need to be very careful to leave instructions about which way you should insert the device to avoid that situation. So some conclusions or take-home messages here. We think computer models could be a great tool to look at the design of some of these devices. We can verify the model using medical images, and they do seem to be accurate. And there are a range of things that we can do with these models that can be quite easy. So in terms of changing the type of material you use for the pessary, what the type of patients that you need to diagnose, and determine treatment options. We know that from our model, all correct positions provide support to different levels, but they are all positive. An upside down position must be avoided because that is going to be disastrous for the patient. So a bit of future work. We're still collaborating with Dr. Arvin, and we're trying to do some more parameter analysis, looking at different models of pessary and how we can apply them to different patients with different conditions. One thing that I'm particularly keen to hear some feedback is in terms of what type of tissues we need to include. Because as the previous speaker mentioned, the pelvic floor is really complex, and you've got interactions between muscles, soft tissues, organs, and they all somehow play a role in terms of the outcome of pregnancy and labor. We started with a simple approach, but where is the end? How many components do you need to include to say, okay, we have now got enough? So some thoughts for discussion, perhaps. I didn't include any pretty pictures because I think we're not that pretty looking, but I'll just, being an academic, I'm going to acknowledge all my founding sources who supported me to do this piece of work, which I'm very grateful, and for knowing Dr. Arvind. And thank you very much.
And do you think you could also model something, this pessary is not for the pelvic floor, it's just for the cervix. It might be easier, as you said, than modeling then different devices which would support certain levator ani lesions or certain connective tissue lesions of the connective floor.
Yeah.
But you could imagine, visionary, that this is possible to work with some experts on this.
Oh yeah, definitely. And I think, yeah.
Thank you very much for an excellent presentation. My question is, I think the failure which we make when we consultate patients with pelvic floor dysfunction, that we try push them only in one group. But according to John Delancey's, I think my hypothesis is we should be able to precise analyze where the defect is localized.
Yeah.
Anterior compartment, posterior, central, level 1, level 2, level 3, and maybe then I was impressed about your presentation. Then, when we know which structure concretely is damaged, we can offer to the patient individualized mechanism, and also this is a place for some, and now we have a huge problem which type of surgery we should offer to the patients, that you know maybe the problems which are the market with the meshes.
Yes.
If we cannot in Great Britain, in Scotland,
Yes,
in Australia, the meshes for pelvic floor reconstructions are not allowed anymore. So therefore I see there's a huge place for pessary therapy.
No, exactly.
Yeah.
I completely agree with you, and I think there's a huge drive towards personalized medicine in different fields, because everybody is different. Everybody has a different background, different activity level, different. In a way, it needs to be customized.
Is there any chance make the modeling, make an automatization? What do you think in the future?
Yes, I think definitely, because I know there's a group, I don't know, Dr. Rudy Lapier, he's in East Anglia. He is doing some computer algorithm that allows you to train midwives in terms of how in different scenarios the fetal head will interact with the pelvic floor muscles. And he did some great work to make that simulation run a lot faster, almost in real time, so that you could almost have a feel of what's going to happen if the baby's head turned this way or that way in a very short period. So it's a real-time response training tool. And I think in the very near future we will be getting there, because now computational power is getting faster and faster, and you can do more and more sophisticated simulations and modeling with them. And that allows you to explore different avenues as well. So if you've got a patient with twin pregnancy, short cervix, I don't know, a history of smoke, you could plug that into the model and see what will be the best treatment options for them. So yeah, I completely agree. And I think that requires more interdisciplinary work, not just between urogynecologists and obstetrician, but also between doctors and engineers and computer scientists to get information across, because we don't practice, so we don't know what's the problem in the clinic. Whereas you know the problem, but you don't know the tool sometimes to solve for those.
And maybe, so I'm a product designer, and so we were working with prosthetics, where we took a scan of a limb, and then with the parametric design, we created a model that automatically fits to the limb itself. So once you have enough data from MRI, you can. There's also a company here in Germany that is using AI to already do this directly from the MRI or maybe ultrasound to analyze what are the organs, and according to this to change the parameters of the design. So I really think it's going this way. So I definitely
Yeah, it's also the least invasive, huh?
Yeah. So there are lots of AI.
The problem is, and then we stop the gap, is also, I mean, there are only 2 randomized trials, pessaries versus operations for pelvic floor disease, one from Rina Taka and one from the Moll group. And, but you know, they haven't individualized the therapy, they just took the most simple ring pessary. So, of course, when you differentiate this therapy, then the results are better. And also the gap of randomization, there's a dogma of randomization, but when you don't care or don't give a clinical audit, and like there is a big difference in pessary trials now, I'm of course biased, but Maria Goya, who did the first trial with good results, it was in one center in Vietnam, where they have excellent results. The doctors were in one center. When you disseminate pessaries without teaching, like Kypros did, send them around and they don't know where to put, and it is not audited whether they are placed upside down or not. And even on the cover of the American journal, notably, it was placed upside down to show the others. Then, of course, the results may be different. It's the same for mode of delivery. And when you disseminate in whole Scotland, I don't expect, when you disseminate in midwives, and I get thank you letters from the control group that the pessary worked so well, I have doubts that this study will have any significant results. No, really, I get thank you letters. I was in the control group of the pessary trial in Scotland, and I got the pessary, and only at 22 weeks, not at the others at 16 weeks. But then after 22, the midwives gave them all the pessary, it seems like. Then, of course, there is a gap. Well, anyhow, I'm biased to say this on big congresses, but I see this. It's like the Radius trial. If you don't teach ultrasound, of course, ultrasound is useless. And this is why you models are very educative.
Hopefully.
And they are not, they are less threatening for the ego of doctors. Yeah.
Well, I think it also helps the patient to
Yeah, the patient as well.
to imagine
Yeah.
how it works